And welcome. My name is Leslie Lytle. I am the Executive Director of Nurture, and we are presenting today the Perinatal Resource Mapping Project, and we are very excited that you have joined us this morning. So let's see, I am having a few, here we go. So give you a little bit of our agenda. We are going to do some brief introductions and then provide some background on Nurture and the Perinatal Resource Mapping Project. We will give you some background, methods, and limitations of this study that we did, go over the results and the analysis and insights. And then we'll spend a little time contextualizing our data, and we won't have an opportunity for a question and answer today because this is not live, but for those that attended the first session on Monday, January 31st, we actually had an opportunity for some small group discussion. So I just want to take a moment first to acknowledge all of the people and organizations that contributed to this project. Nurture, the University of Richmond, Richmond City Health District, and Postpartum Support Virginia were the organizations. And you can see the students and individuals that contributed to this project here. And today, myself, Leslie Lytle, Isabella Araujo, Emily Schreer, and Sarah Shaughnessy is not with us, but we were the primary people who contributed to the actual presentation and who will be sharing it with you today. To give you a little bit of background about Nurture, we were founded in 2013 by a group of mothers and perinatal care providers who recognized the need for a stronger maternal health village. Our mission is to improve the health and well-being of childbearing families through fitness, education, social support, and community engagement, which comprise what we call our 4 pillars of move, learn, connect, and inspire. Our goals are to establish a perinatal resource center offering education and support services for childbearing families and also for the professionals who serve this audience. We also hope to serve as a hub for a better networked perinatal health ecosystem and a gateway for connecting individuals with community resources. Our 2020 to 2022 action plan focuses on 3 key areas: breastfeeding advocacy and support, improving the local maternal infant health ecosystem, and improving access to perinatal supports and resources. And you can see under this area some of the things that we worked on in 2021 and that we are currently working on in 2022, which is the Perinatal Resource Mapping Project and the directory. And now I'm going to turn it over to Isabella, who will introduce herself and take on the next portion of this presentation. Take it away, Isabella.
Hi, everyone. My name is Isabella Araujo. I recently graduated from the University of Richmond in the spring of 2021. I originally started working with Leslie and the Nurture team through a U of R class, Women's Health Psychology class, which had an outreach component. And then ever since then, even once the semester ended and I graduated, I continued to work with Leslie and the Nurture team because I was really passionate about this project. Slide, please. So we'll jump in. So the Perinatal Resource Mapping Project was a response to our 2021 COVID-19 survey of 742 postpartum parents across Virginia who indicated across all demographics that mental health support, lactation support, and doula support were among their top needs. This emphasized the need for one common place of information as well as easier access and awareness of assets within the local community. We had applied for a grant that required a landscape analysis of perinatal health providers, and although we didn't get the grant, we went ahead with the project as we had student interns, including myself, who were ready to work. Slide, please. So on this slide, we'll take a closer look into our purpose and goals of the project. So goal number 1, first estimates of provider count. This was a more immediate goal, offering a first look into calculating the numbers of the 3 types of providers that were operating in the planning district. And we do acknowledge that there were limitations of the study, one of them being the convenient sample we have. However, for these providers, especially for those in very unregulated industries like doulas, asset estimates, even on state or national levels, don't exist. So this project might be the first look into cataloging the resource that we have available. Goal number 2, asset mapping. Beyond the number of providers, another more immediate goal of the project was to analyze our data and to measure how well providers are distributed throughout Planning District 15 and how well they reflect the demographics of the communities that they're serving. The data collected will be used to illuminate gaps in services as well as service areas which may exist. And these gaps can hopefully be addressed by the collective work done by health organizations. Goal number 3, provider trends and demographics. This is another more immediate goal and today's focus of the presentation. We'll be looking at the data we have on individual providers and asking questions of it, including, do providers reflect the populations they serve? Are they accessible? What types of providers populate each field? And are there any barriers to entry? And lastly, the public-facing database. This is the ultimate long-term goal of the project, which is to create a greater Richmond-specific live perinatal database that will map existing resources in our area. And then expecting parents and community members will be able to use this database to easily search for and better access the exact resources and providers that they need, whether they're searching for a provider who's accessible by public transportation, someone who might specialize in LGBTQ families, or someone who offers free or pro bono services. Slide, please. So on this slide, we have the overview of the project timeline. A provider survey was conducted from April to October 15th, 2021 by 5 University of Richmond undergraduate students, as well as other volunteers who performed outreach to contact providers in the 3 categories previously mentioned: doula support, lactation support, perinatal mental health counseling. Some of the outreach methods that were used were email, phone, online databases such as Doula Match, 2Labor, National Black Doulas Association, Virginia Breastfeeding Coalition, and many more. Other forms of outreach were using social media, Facebook groups, Instagram, LinkedIn. We found that doulas were the easiest to find and contact online. However, though many doulas had an online presence, many were defunct or have not been active since the start of the pandemic, which may be suggesting a high turnover. Volunteers, including myself, had better results with follow-up emails, especially personalized emails, and emails with subject lines specific to the person who is receiving the email. A total of 132 survey responses were collected through October 15th. The data was then downloaded, cleaned, and analyzed by Nurture volunteers along with data analysts at the Virginia Department of Health. This step included asking questions of the data and determining any limitations which may exist, which we'll be expanding on later in the presentation. But overall, we need to acknowledge that our results may not completely represent all providers practicing or offering services in Planning District 15. We were, of course, limited by those who responded to our outreach and who filled out our survey. Slide, please. So as I previously stated, we initially started with 3 provider categories based on the results from Nurture's 2020 and 2021 COVID-19 survey for pregnant and postpartum parents. And upon reviewing the data, it was clear that a significant number of respondents provided services in more than one category, which we primarily saw in the doula and lactation groups, necessitating the creation of 5 groups for data analysis. The doula and lactation group includes the 29 respondents that provided both doula and lactation services. The 2 or more services groups includes the 4 respondents that provided services across other multiple categories. And now Emily will jump in with provider demographics.
Thanks, Bella. So I'm Emily. I am a public health associate in the CDC's fellowship program, and I've been working at Richmond City Health District for a little over a year on their maternal and child health team and COVID outreach team. And I was introduced to Nurture through my work on their maternal and child health team. So now we're going to move into a discussion of our survey data, specifically looking at provider trends and demographics. Next slide. So as you can see in this first graph, each of our 5 provider groups that Bella mentioned is made up of predominantly white providers. And it's important to first note that our response population was majority white. It was about 68% white. And our outreach methods could have impacted our results. We are very dependent on providers with an online presence, and like Bella said, on providers who engaged with us, who responded to our outreach, and who are willing to take our survey. However, we also want to note that these trends that are reflected in this graph were mirrored and reflected in the literature that we conducted alongside of our survey, especially in fields like lactation support, which is that second column in this graph, where we see the most uneven racial distribution between white providers, which is the light green bar, and providers of color, which is the dark green bar. And we'll talk about that more in later slides. Next slide. This slide looks at age by the 5 service provider groups. And you can see that the yellow color, which is our 30 to 39 age group, is the most common age range throughout our survey. And if you look at the second column again, that's our lactation support group. That's where we're seeing the most even age distribution, with about half of respondents being under age 49 and about a little under half being over age 50. And this also fits with trends that we noticed in research and literature of the lactation field having a very prominent vanguard of older, and as we saw in the previous slide, white women at the top of the field. And this differs if you look at columns 3 and 4 in this chart, which are our doula groups, doula support, and the 4th column, doula and lactation support, where we're seeing the ages skew a lot younger. In these columns, we're seeing just under 3/4 of respondents under age 39. And this could be because of many reasons. It could be because of high turnover, as Bella mentioned in the doula groups. It could be because of lower barriers to entry or burnout. Doulas are often expected to do high intensity work for comparatively lower wages when compared to other fields represented on this graph. And doulas are also often inspired to come into the field because they're motivated by their own births, whether from a very positive or unfortunately very negative experience. But the result of that, we see the most representation from the 21 to 29 age group in the doula columns, as well as the least representation from the older age group, specifically the 60+ age group. Next slide. So now we're looking at a question from our survey which asked about the settings in which providers were practicing. And respondents could choose more than one answer to this question if they provided services across multiple settings. Next slide. So first we'll look at practice settings for lactation support providers. And you can see, looking at this graph right away, it looks like the majority of lactation support providers are practicing in a hospital setting. And then once you get past that, the longest bar, there is some variation with providers practicing in freestanding clinics, in client-patient homes, and even some in virtual and private practices. However, when we looked a little bit closer at the data, we found that lactation providers who took our survey who have an IBCLC credential, and for those of you who don't know, that's an international board certified lactation consultant, that the majority of IBCLCs in our survey were practicing in hospitals. So this means, looking at this graph, that IBCLCs are making up the majority of lactation support in hospitals represented in our survey. And that's really interesting. We'll talk about that a little more later in our presentation when we talk about credentials. Next slide. So next we're looking at practice settings for perinatal mental health providers. And you can see that far and away the most common settings for these providers are virtual and private practices. And our outreach to these providers kind of echoed these trends of the pandemic and even pre-pandemic of mental health providers moving their practices online and thereby creating larger service delivery areas for themselves, whether that means wider Virginia or even further than that across the country. And the flip side of this is this could mean a wider range of opportunity to receive services for childbearing families in our district, because they're no longer limited, as they might have been in the past, by providers who are located in our district or who have a brick and mortar establishment in our district. And if you go to the next slide, we'll look at the final 2 groups for practice setting, which are our doula groups. And the blue graph on the left is our doula support group, and the green graph on the right is our doula plus lactation group. And you can see right away, looking at these 2 graphs, that they look a little bit different than the previous two, especially the perinatal mental health provider graphs. We see a lot more distribution across the service settings and a lot more variation. And these graphs really just illustrate the emerging industry of doula work that often necessitates high flexibility and meeting clients where they are, instead of relying on clients to come to them. And in the next slide, we'll look at this practice setting question from one more viewpoint. Because respondents were allowed to choose multiple responses for this question, we can look at response combinations. And interestingly, we found that the most common response combination to the settings question was chosen by 16 different individuals. And they reported that they provide services at a birth center, client patient home, hospital, and a virtual practice. And we found that every single person who chose this most common response combination provided doula services in one way or another, whether just as doulas, as doula and lactation support providers, or in our 2 or more services group. And this is just another illustration of the fact that doulas are really practicing everywhere. Next slide. So now we're looking at another question on our survey, which asked respondents about the forms of compensation that they accept. And for this question as well, respondents could choose more than one answer if they accept multiple forms of compensation. And looking at this question now, we're kind of moving, we're still looking at provider trends, but now we're adding the question of accessibility into the mix. So if you go to the next slide, we'll first look at compensation by lactation support. So as you can see in this graph, we see a pretty good list of options. We see private insurance, and right behind it, Medicaid as an option, fee for service, for your pro bono, sliding scale, a really great representation of many options, and really just a visual representation of the increased access to lactation support that families in our planning district have access to. And this, we see a little bit of a different story on this slide for our doula groups. Here we see that the most common form of compensation accepted is fee for service. And really, there's no competition that is the most common. We see private insurance and Medicaid as really not an option in these cases. And what we might even see is doulas taking it upon themselves to increase access to their own services, sometimes even at their own expense. And that could be by offering more free or pro bono services, sliding scale. And one doula even wrote in her survey short answer that she accepts barter services or goods in exchange for her doula work. Next slide. And that, of course, differs now if we look at perinatal mental health, where, again, fee-for-service is common, but Medicaid and private insurance are options again. And this just shows a different option that would increase access to mental health services for families in our district. That really is not the reality now for our doula groups. Next slide.
Here we go.
So now we're going to start looking at credentials. And this question on our survey asked providers to check off or write in, if it wasn't already represented, the credentials, certifications, or degrees that they held. And we then grouped those together based on category. And you'll see what I mean more in the next slide. So this first category here is our lactation-related credentials and certifications. So all of these listed have to do with or are commonly held by those in the lactation field. And in this word cloud, the larger a word is, the more common it was in our data. And as you can see, IBCLC, which again is the International Board Certified Lactation Consultant, was the most commonly held credential. And not far behind is the Certified Lactation Counselor, the CLC. I won't read through all these credentials, but it is really just interesting to see visually represented the variety and diversity of credentials and certifications offered in this field, and even just those represented in our relatively small survey. Next slide. Now, if we look at our lactation-related certifications and credentials by our 5 service provider groups, we see that, unsurprisingly, the providers that hold the most credentials in this category are our lactation support providers in the second column and our doula plus lactation support providers in the 4th column. However, if you look a little closer, there are clear credential differences between these 2 lactation provider groups. We found that only one doula, only one person in the lactation doula, and only one person in the doula and lactation provider group held an IBCLC credential. And you'll remember in the previous slide that that is the most commonly held credential in this category. So that means that the rest of them, the vast majority of the IBCLCs, are held by providers in the lactation only support group. And that is the second column here. And if you're curious, the majority of credentials held by providers in the doula plus lactation support group was the second common, of course, the CLC credential. But the important thing to remember here is that there is a clear credential split between these two groups. And I want you to keep that in mind as we go to the next slide, where we have our medical related credentials and certifications. And the most common in this category was our RN/BSN, kind of a general nursing degree, which is what was listed on our survey. And the rest of them are kind of more specific nursing degrees or medical degrees, and most of them were write-ins. And you can go to the next slide, where we look at medical related degrees by service provided. And we see an extreme concentration of medical degrees in our lactation support group that is not also reflected in our doula plus lactation support group. So looking at this graph and looking at the second column in particular, keep in mind that when we're seeing this lactation support group, this is where we're seeing the IBCLCs. This is where we're seeing the medical related degrees, which, as we established on the previous slide, are primarily nurses. And if you go to the next slide, we'll just take a minute to give a little bit of background and context into lactation credentials and the lactation field for those of you who might not know. Because it really does seem sometimes that the lactation field is white and nurse dominated almost by design. Though there are many, many credentials in the lactation field, as we saw in the first word cloud, the IBCLC credential is widely viewed as the gold standard. However, it is very expensive and time intensive to achieve this credential. Someone who is not already a nurse must have over 1,000 hours of one-on-one breastfeeding support practice clocked and have those hours signed off by a direct supervisor or IBCLC mentor. And in most cases, IBCLC is expected to be compensated for their time. And unlike with white women, Black women and women of color are few and far between in the breastfeeding space. And this means a smaller network for finding a mentor. And even after overcoming those first few hurdles on this little roadmap on the slide, the IBCLC exam itself can be cost prohibitive. And I won't read this quote here on the right side of the slide, but it really does illustrate the barriers that many aspiring Black and professionals of color who are looking to achieve this credential and build a career in the lactation field have to overcome, especially if in addition to being women of color, they also are not nurses. And the result of all of this is that we have a lactation field, which is shown in literature to be predominantly white and nurse dominated. And this is importantly reflected in our data from Planning District 15. So now returning to credentials, I'm going to pass it back to Bella.
Thanks, Emily. So yes, returning to credentials, we'll now look at the credentials and certifications for the doula related category. And as Emily said, the larger the word is, the more common it was within our data. The credentials in this group are those we categorize as pertaining to childbirth. The most common certification in this category by far was certified doula, which is a general certification. Some doulas held specific certifications or were trained by organizations like To Labor, DONA, or MyBirth. This word cloud is evidence of little standardization. Slide, please. And upon speaking with people who work in this space, we found that in order to become certified as a doula, the biggest barrier to face is an individual's ability to pay for their training. And although there are many options in terms of certifications, standard subjects of doula training include physiology of birth, labor, postpartum, and recovery, informed decision-making, informed refusal, and understanding of common medical interventions that may happen during the birthing process. Slide, please. These are the credentials related to perinatal counseling. The most commonly held was licensed clinical social worker, as you can see, followed by licensed professional counselor and licensed clinical psychologist. And as many would guess, perinatal counseling related credential holders are almost entirely made up of perinatal counselors. Slide, please. This section asks respondents where they practice within Planning District 15. Respondents could give multiple answers if they practice across cities or answer all of the above. Below are the top 3 service areas with the most providers. Unsurprisingly, providers were concentrated in and around Richmond City and Henrico. Each service is either based in or is actually servicing that particular area. And to contrast that, on the next slide, we have the bottom 3 service areas. And as many would guess, rural counties were the lowest service areas. Powhatan County, New Kent County, and Charles City County each have less than 24 providers, either based in or providers that service these locations. And as you can see with New Kent and Charles City County, they're actually a lot less than 24 providers or 23 providers. Slide, please.
Okay, so I'm going to pick up here talking about kind of getting into a discussion of contextualizing our data, connecting it to some existing research and mapping that the health department, Richmond City Health District, and VDH has been doing. So you can go to the next slide. So first, we're going to look at 3 maps, looking at regional demographics and some indicators. Next slide. Can you go back one? Yeah. So looking at this first map, we see racial composition for Richmond City, Chesterfield, and Henrico. And although now we're looking at kind of a new area, this doesn't show the entire Planning District 15, but we see kind of as Bella mentioned, the 3 most populated areas, and this was where the majority of our providers were located and practicing. So it is kind of like a really good snapshot of the planning district. And looking at this map, the reddest parts of the map, which we see kind of near downtown Richmond and East End, are predominantly Black, while the bluest areas, which we see in the West End and Chesterfield, as well as a few other areas, are where we see the predominantly white populations. And any areas where you're seeing some dark purple or light purples are areas where we see some mixed populations. So keep this map in mind as we look at the next map, which shows regional median household income. And as you can see on this map, looking at the purple areas, that's where we have the majority of people living in households making over 120 and even over 200% of average median income. And looking at the white areas, which again, we're seeing kind of in Richmond downtown, East End, and South Side, are those living below the average median income and making less than, in the whitest areas, less than 80% of the average median income. And if you go to the last slide of our modal mapping, contextualizing section, here we're looking at the regions that are classified according to the CDC's Social Vulnerability Index. And the Social Vulnerability Index uses a ranking of 14 social factors. Among these are the percent of households living below the poverty rate, the percent of households with unemployed people, the percent without a high school diploma, the number of single parent households, the number of households with no vehicles, and other factors like that. And as you can see again, there are definite patterns looking at the 3 maps of the regions with the highest social vulnerability, the highest rates of those making less than the average median income, as well as racial disparities. So if you go to the next slide, now we're going to bring that contextualizing conversation, widen it again to Planning District 15 as a whole, and bring it back to a specific maternal and child health lens. And the data that you see in this slide is also from VDH and PRAMS. So looking at the first, kind of at the top right of the slide, the pie chart, this comes from VDH population data from 2019, which shows that in 2019, there were about 15,144 total live births in Planning District 15. And of these, about 9,000 were white, about 4,600 were Black, and about 1,400 were other births of color. Looking at the middle of the slide, in 2019, Virginia PRAMS found that about 14% of respondents had symptoms of postpartum depression, and that fits right within the national reported rate that among new mothers, between 10 to 20% of them have some kind of symptoms or clinical postpartum depression. And the reason that that rate, that there's such a range there is because of the cases that go untreated and unreported. And using this rate, we can estimate that there might be about 2,270 postpartum people with PPD symptoms in Planning District 15 in 2019. But of course, the true number could be much larger. And moving down to the percentages at the bottom of the page, these are extrapolated from PRAMS from 2019 and specifically for Richmond City Health District. And it found that when interviewed at 2 to 6 months postpartum, white parents reported, 86% of white parents reported breastfeeding, while that number was only about 44% for Black parents. And for PRAMS as a whole, they found that when parents of all races were asked about the reasons for stopping or not continuing breastfeeding, some of the most common responses were that breastfeeding itself is too hard, or that they had a difficulty latching. And those, of course, are two issues that lactation support providers are trained to help with. So when looking at this slide, when looking at the total number of live births in our planning district, when looking at the potentially just a fraction of the number of people with postpartum depression symptoms who could use the help of a perinatal mental health provider, when looking at the racial disparities in breastfeeding rates, the number of people who could benefit from the services of a lactation support provider, we have to wonder, are there enough providers addressing these issues and helping pregnant and postpartum parents in our planning district, especially families in minority communities, thinking about the maps that we just saw, and thinking also about the demographic makeup of the providers that we are able to connect with and map so far in this project. You can go to the next slide. So our outreach efforts, which we talked about at the beginning of this presentation, they utilized the resources and skills of college-aged, internet-savvy people who had the time and the patience to search for providers online, to follow up multiple times and track outreach efforts. And they didn't have, too much urgency to connect with providers immediately. And even that kind of framework is really not it's really just not realistic for many parents of young children who need services immediately or need to connect with providers right away. But through that outreach, we were able to connect with and get responses from 75 doula support providers, 61 lactation support providers, and 28 perinatal mental health providers. And of those, 17 were doulas of color, 13 were lactation support providers of color, and 7 were perinatal mental health support providers of color. Now, of course, when even beginning to talk about the number of providers in our area, we want to be very clear of the data caps and difficulties that go into calculating this, or even being able to compare the numbers on this slide with something. Because first of all, as Bella mentioned at the beginning of this presentation, those numbers really don't exist. They don't exist for our population yet, and they really don't even exist on a national level. Think about populations like lactation support providers, many of whom are not solely lactation support providers, but might be primarily nurses. Think about doulas. In the state of Virginia, doulas don't have certification requirements, which means that there's no one registry to go check and make sure that every doula is counted. And although some doulas do practice in organizations and collectives, many are entrepreneurs and practice individually, and they might make an online profile for their business and leave it active after they stop providing services or take a break, which we encountered many times during our outreach, and that makes finding a provider and counting them much harder. But still, returning to the goals of this project, which again were motivated by the needs of parents and childbearing families in this area to be able to more easily find, access, and communicate with providers on their own. While we acknowledge that these numbers here are not an accurate representation of the true number of providers in Planning District 15, we ask if they could be an indicator. Could they be a representation of the number of providers who are easily accessible for parents right now? And if so, what might these numbers tell us about the current state of provider availability and accessibility in Planning District 15? And if not, what are the next steps to finding a more accurate picture? We don't pretend that there are any easy answers to this question, but we hope you join us in trying to start brainstorming and thinking about the next steps. And I know we won't have the chance today to have that discussion, but maybe we can put the questions on the screen if anyone wants to watch this and just think about it. I'll pass it over to Leslie to wrap it up.
Yes, so thank you very much, Emily and Isabella, for all your work on this project. And as we close our presentation today, we just invite you to reflect on the presentation itself and think about what your top 3 takeaways are. What is your vision for perinatal provider demographics and accessibility in Health District 15 or Greater Richmond? Because Health District 15, all of the births that take place in Health District 15 generally feed into one or the other of the hospitals or providers in Greater Richmond. And then what first steps can we take to ensure better provider accessibility for childbearing families in Health District 15? We thank you for your time today in watching our presentation. If you have any questions, please feel free to reach out to me at leslie.lytle@nurturerva.org. And we hope to continue the conversation on how we can improve the local environment so that we are better supporting our childbearing families. Thank you so much.